to get it right first time. Actually, as we've all heard, Get It Right First Time observed by Professor Tim Briggs, where he went around the country to review units. Now, of course, in his case, it was for everything, heat, need, and everything. But why I took this, because I did 6 months of secondment top-up training at RNOH, Royal National Hospital, and these 6 months were in the shoulder unit. And what struck me, of course, most of the surgery are as a tertiary referral. About 50% are revision of work done elsewhere. And what struck me, because I worked in hips and knees before, is that if this result had been perceived or seen in hip and knee surgery, it would be a problem. But in this upper limb, it wasn't. So, as you can see, GIRFs, the whole idea of GIRFs, supporting the following elective orthopedic care, improved patient experience, re-empowering clinician, improved patient safety, better outcome in terms of joint longevity, infection, SSI, and acquired complication, readmission, and mortality. The whole idea is there is significant taxpayer saving from reduced complication, infection, readmission, length of stay, with directed care pathway, reduction in loan kit and cost, because if a DGH does revision hip to get things on loan cost more than, for example, a tertiary referral center, which they use it every week, every day. So this, which now, with the constraint, part of it, the constraint on the NHS to save, I don't know how many billion pounds a year. And that's what Professor Briggs was trying to improve outcome, and at the same time make it more cost effective and reduce cost. And here is Professor Briggs. He was a POA past president, getting it right first time. Musculoskeletal disorder has the third largest budget, 10 billion. Commissioned by GP, there is an aging population, increased life expectancy, obesity, increasing demand for patient. Primary care trusts have reduced their referral to save money rather than clinical evidence, and denying patient access to life-changing surgery. Actually, this I was involved with working in Ealing Hospital, but also I was at Stanmore, and you can see GP now, the tab is closed from the top. So the GP now, there is less referral. You've got hip pain and got osteoarthritis, refer to physio and some painkiller and nothing else. And this is a problem. Okay, so I work in Ealing at Imperial College, and at that time I worked at Royal National. I still go one day a week, but in the upper limb unit with Mr. Bailey, Mr. Mark Farworth, Deborah Higgs, and Simon Lambert. But the series you're gonna see, so it is a retrospective study, patient who had surgery at RNOH, upper limb unit, by the two senior authors, Bailey and Lambert. Number of patients reviewed in this 13 months, 311 patients. We reviewed the operation note, clinical note, correspondence, radiology review, and relevant investigation. So result, out of that, we got 5 groups. There is the arthroplasty group, which 100 patients. There is instability group, which is 67 patients. A rotator cuff and impingement group, 60 patients. Complicated fracture, 68 patients. Arthrodesis group, about 16 patients. Arthroplasty, 100 patients. So there is a lot of the cases where primary arthroplasty, hemi, resurfacing, total shoulder, total elbow replacement. There was revision shoulder arthroplasty after hemi, where there was iatrogenic cuff deficient and glenoid deficient shoulder because of putting large head, and revision arthroplasty for infection and loosening. As you can see, this is X-ray of what's been done in arthroplasty. So it's a wide range from total shoulder to just resurfacing. And revision shoulder arthroplasty, it was iatrogenic cuff deficient and glenoid, iatrogenic cuff deficient with intact glenoid. So what is used in Stanmore, fixed fulcrum increased offset reverse shoulder arthroplasty is the Bailey Walker prosthesis, which is captive prosthesis, and it is widely used at RNH, but not the rest of the UK, with, according to them, good results. And there was also post-traumatic humeral head replacement, which was published as well. So revision shoulder arthroplasty, also, there was iatrogenic cuff deficient and glenoid deficient. So the first group was glenoid was intact, so you put the Bailey Walker. But if there is also the glenoid is deficient, you put this CAD-CAM, which is computer-assisted device by computer-assisted manufacturer, okay, which look like a hip in the shoulder, okay. And as you can see, the cup, the metal cup, is screwed to the scapula, spine of the scapula, to the coracoid, so everywhere you can get screwed. And then you put in the metal cup, you cement a plastic cup. And this was reviewed and published by Journal of Elbow Surgery in 2013. So these two groups of surgery which were undergone at RNH. Now, shoulder instability, we've reviewed 67 patients, and we put them in two groups. First group referred for surgery, and the second group referred after surgery. So referred for surgery to Stanmore because it's very complicated, or referred after surgery because of problems. So all of us are familiar about the shoulder instability Stanmore triangle, type 1, type 2, type 3. Type 1, which is traumatic structure, type 2, atraumatic structure problem. Type 3 is muscle patterning, where there is non-structural problem. But of course, there is a combination. So it can be 1, 2, or 2, 1, or depending on. Okay, instability group. So there was MPT reassessment by physio, by the surgeon. Patient did have an EMG, diagnostic arthroscopy, and try to apply the Stanmore triangle concept. And this was published by Jaggi and Lambert in 2010. Okay, so the whole idea is to confirm the diagnosis. And now, type 3, surgery is contraindicated where there is muscle patterning. As core stability and posture exercise is enough. With selective rotator cuff activation. By type 2, some do require surgery, but some don't. Type 1, all require surgery. Okay. So there was, the other group was referred after stabilization. Patient who had anterior stabilization, they had biofeedback, but worsening symptom, and some of them had revision surgery. The main thing that the revision surgery which was done was actually undoing the first surgery because of wrong diagnosis. And there was wrong diagnosis and wrong operation or inadequate operation. So misdiagnosis and there was inferior laxity or type 3 or type 2, or there was glenoid erosion. So you can see wrong diagnosis, wrong surgery, and wrong management. Now, the That's the instability group. Now we go to the rotator cuff tear and impingement, which had 60 patients. So there was arthroscopic repair in most of the cases, and there was also open repair. There was also of the rotator cuff. There was cases of muscle transfer, and there was a specialized physio rehabilitation program at RNMH, which is geared for this sort of surgery. Now, in the GERT report by Professor Briggs, he found that there is 544% increase in the rotator cuff tear repair, so 5-fold increase. The impingement, there is what we found that there was failure to understand the cause of the impingement. There was some defective surgery, and also Professor Briggs' finding going around the country that there is 746% increase in ASD or SAD in the last 10 years. With no evidence-based proof, but there is this increase. Now, complicated fracture and other pathology, we've seen 68 patients where there was failure of fixation, infection, and wrong surgery. So here is a complicated fracture treatment. For example, here, united clavicle was very short, causing symptoms. So the patient will have an X-fix and lengthening, clavicular lengthening. Now, drastic complication, you can see patient seen in DGH had this fracture proximal humerus, had this fixation, and came to RNOH with his shoulder pouring pus. And this, the X-ray after removal, and this was a young patient in his 20s. So you can see how dramatic and drastic. Also, improper management. This patient will have excision of the clavicle for a possible tumor, which turned not to be tumor at all, and they've done prosthetic clavicular replacement. The arthrosis group is 16 patients, where the patient will have scapulothoracic fusion or glenohumeral fusion. Scapulothoracic done, as you can see, and the glenohumeral fusion, where patients have pinning of the glenohumeral joint first as a test, and then if it works, because patients are in pain, then they get glenohumeral fusion. Conclusion, specialist upper limb services should only be done in specialist unit with an appropriate critical mass as a part of specialist network should be subject to regular transparency performance review. Now, single pyramidal concept for primary and secondary care, and we should have Sphinx leadership with lion heart and human face as we are treating patients. Thank you.
Good. Any questions?
The cases which you are presented, like excision of clavicle and replacement, complete clavicle, is it the case done in UK?
Yes. It's done in UK and revised in UK. Yes.
All the cases, when you say
So all these cases are cases which were done in DGH and being referred to Stanmore Royal National Hospital for second opinion or for tertiary referral opinion. Yes.
You know, when you're sitting in this slide that all the cases, we have, if it's high problematic cases, you have to refer to special. When will we know, when you're seeing a patient at the time of consultation, that this is going to be a problem or not? At what level will be drawing a line? This is highly specialized. This is big.
Okay, I think
because that's one of the problems we are always facing. When you're in a routine clinic, for example, based upon your own expertise, you can make a decision or not. But the outcome might differ. For example, in that particular case of a young patient with an infection, the fixation might be poor or infection might come here or there. But what would you say, where will be drawing line? This is very high specialist.
all right.
Because that's what, if I work in DGH, I have the dilemma. if I'm going to refer all these cases, then I'm doing more of defensive practice. Then, you know where I'm coming from. I'm always being defensive, that this is way beyond me, then I'm losing my
Can I answer
capability.
one?
Adding on to this, I mean, if you say specialist centers, if you got a certain upper limb surgeon working in your department,
Yeah.
and they can do the case, is that okay, or you want just want every fracture
Okay.
to go to?
Can I answer? Now, all these cases which were done by upper limb surgeon in DGH. Now, the problem is that this upper limb surgeon in DGH are stand-alone units. And it's not only the surgeon, it's the critical mass. So how many proximal humeral fixation they do? And the whole setting, so we are looking at it from all aspects, the whole setting, of theater setting, nurses, everyone who are not used to this. So the surgery take longer, higher infection. I'm not saying it might get an infection if it's done at Stanmore. Of course, Stanmore is not infallible for infection, but the infection rate in Stanmore for such cases is lower. Second thing, for example, the other, apart from that, wrong fixation or whatever, yes, it does happen, but in Stanmore as well, but with less percentage of complication, because it's the volume of cases. Okay. The problem is, that's what we are suggesting. We are not saying upper limb surgeon don't do it, but we need to have unit. So there is no standalone. So we have a critical mass, bigger number, and people together. Because now I think the way forward is even to have more than one surgeon operating on the same patient. It's not only one. And that is the problem. And I think the message from Stanmore, which I had, and I got it for myself, that upper limb surgery, shoulder and elbow, are not as simple as people think. So it shouldn't be straightforward for DGH, should be for tertiary referral or upper limb unit where there is more than one surgeon.
Far away, yeah.
Shenouda, are you talking about elective orthopedic upper limb surgery, or are you including the traumas or upper limb trauma? Because upper limb trauma, in my opinion, might be a bit harsh. Any general orthopedic surgeon should be doing it. Yeah. You cannot really say even the upper limb fracture clavicle or fracture proximal humerus should go at tertiary referral center. If you have a problem getting complications from your DGH referrals, then you need to check your training. There is a problem with the training then. It's not a problem because in Paris I have seen arthroplasty, shoulder arthroplasty surgery done by a hip surgeon. He does shoulder arthroplasty as well as hip arthroplasty. So we have to define exactly what you want to be sent to a tertiary referral center.
Yeah, I mean, I think there are a couple of things really. The Royal National will be receiving their referrals, those 100 and whatever total number it was, 130.
Yes.
130 patients. They won't all have been coming from one hospital.
Yeah.
They may have been coming from 100 and
Yes.
something.
Yes, this is the thing.
130 hospitals. So the guy who has fixed 30 proximal humeral fractures and had one infection may be no different to Stanmore or anywhere else.
Yeah.
But the problem is the further management of that obviously does probably need to be done in a specialist centre. So in relationship to the cases, Shenouda, you present, the reality is we need to know where they come from, really. Not we need to know if they're all coming from one centre.
No, it's the other one.
If they were all coming from one centre,
No.
then the logical thing is that person in that centre should stop doing the cases.
No, they are
Because
not.
that would be inappropriate.
Yeah.
And the thing that I have suggested, and actually said it at, I think when I did the Robert Jones lecture last year, is that it is better to pick up the phone and phone a friend than to pick up a knife and rip a line. So if you honestly think you've got a difficult case, be it a fracture or an elective situation, and you think this is beyond me, then there will be some friend of yours at the Royal National Orthopaedic, or if you're in the north of England, somewhere else, who will be delighted to take it off your hands. And I don't think we should be ashamed at referring patients that way, because the patients will get a better result, and it stops your coronary arteries getting furred up and causing you a problem as well. So I actually think it needs to be treated with logical sense. Everyone will have some complications. If your complications, fixing elbow fractures or distal radial fractures or whatever it is high, then realistically you should put your hand on the heart and say, that's probably my fault, I should stop doing it. Probably.
There is a certain amount of internal referral system we have in our hospital. I'm sure we have in many different hospitals. If there's a very complex shoulder trauma, we have shoulder surgeons to do it. So his trauma list would be mostly upper limb or say shoulders. So it's not that a general surgeon should have to do everything. I mean, I'm
I think the current practice is
That's what the practice is in all hospitals.
Yeah, most of the practice change that between them they're sharing. Even in a hospital, if there's an upper limb trauma, they do share. The upper limb surgeons tend to come and do this cases. Medical trauma is
Can I just comment, because look at the same fracture proximal humerus and fracture neck of femur. They are proximal bone, long bone. Of course, fracture neck of femur, I used to do it even at SHO level long time ago with no problem. Okay, but fracture proximal humerus done even by consultant in different hospitals, there is higher complication rate. And according to Mr. Lambert and Mr. Bailey there, which I do agree, that they are, upper limb surgery is super specialization. So it might probably need one thing, longer training to do these cases. Let me finish. And second thing is the numbers. Probably the neck of femur will get 200 per year. So you get enough number, okay? But the proximal humerus or elbow fracture, the number even in specialized unit are not that great. So if you do it in a standalone upper limb unit, the number is very low, and with this very low number, I'm not only blaming the surgeon, but the whole setting is not, and also the physio itself. Now, we referred also to the instability group. Instability group, there was wrong diagnosis in other hospitals before any surgery. So
yeah, but I think again, one has to appreciate that the Royal National Orthopaedic cannot cope with referral. So it comes down to the integrity of the surgeon at the end of the day.
Yeah.
And if the integrity of the surgeon is such that he says this is beyond me, then he either asks his colleague locally or he refers it to a more specialised unit. And there is very little in the way of upper limb surgery that can't wait till tomorrow or the next day, on the whole. There will be some, but on the whole there won't be. Just out of interest, we better finish and move on. Can you show me your scapulo-thoracic fusion X-ray? Because that's bound to fail. That I couldn't get this. Whether it's done at Royal National, I'll explain why.
What was done on the humeral infection? You didn't show what the result was done on
It
that.
just shows that one.
Okay,
again.
So it doesn't matter.
No, I just see what they did.
I don't think he has.
You can't refer it.
I'm just trying to get
What will the other
Yeah.
They won't do the practice anyway.
Just out of interest.
I mean, it's not
To suggest something.
what they do, and they don't just lower the
But I think these things are good because they make us think, don't they? So we all think it. That one. No, there was one scapulo-thoracic. It's not that one. It's the one
Just
before. I think. Yeah.
Okay.
So if you look in the literature, this is the sort of thing that is done. And when you think about it, what have you got? You put a chunk of metal down there and holding it with 3 wires or 4 wires. How the heck is that ever going to work, realistically? So, I don't know. I mean, you look at the literature and there are reports of it, so I'm not saying it doesn't work, but realistically, we've moved on in our techniques that we have available. And what we've done in Sheffield a number of occasions now, and Ian Trowell and I did together in Wrightington as well, is actually, why do we do that? I say to trainees, if you've got an idea about something, then you need to look and see if it's been done before. If it's been done before and it's failed, you shouldn't repeat it unless there is a reason why things have moved on and changed. So what we've been doing in the small number, and we've published it in Shoulder and Elbow, is actually plate the rib to the scapula at least 3 levels. You can always get 3 screws in the ribs, and you can always get 2 screws in the scapula, going through the scapula into the rib. You can't get 3 on this side, and the reason you can't get 3 is because the scapula and the ribs move away from each other. But you can plate 1, 2, 3 ribs with, then you've got 3 screws there, up and down vertically, 1, 2, and 3. And you've got 3 screws there, and on the other side you've got 2, 2, and 2, vertical as well as horizontal. And that gives really quite rigid fixation. Because you've got, when we talk about fixing fractures, we always want at least 3 cortices each side of the fracture. So if you do that, and I tell you that, I think that will fail. But anyway, that was just an observation. We ought to move on. We've got one more presentation. Is that all we've got left to go? Let's have the last presentation. But that's good, and it makes us think, and that's important.